Assalamu alaikum warahmatullahi wabarakatuh. Welcome back to the channel of Stand Medical Notes, or you can call it as Stand Medical Lecture also. So let's begin. So uh, we were started a new discussion, that is cardinal manifestation of endocrinological diseases. So first we were discussing about the thyroid gland. So we in the previous video we have discussed the normal physiology in detail. Today we will discuss the first abnormality, that is hypothyroidism. Okay, let's begin with the name of Almighty then. So what is basically hypothyroidism? Nothing but low thyroid hormones. Okay, so concept and definition: subnormal production, secretion, or peripheral tissue action of thyroid hormones, that is T3 and T4, is known as hypothyroidism. What is that? Subnormal production, either production, subnormal production, or subnormal secretion, or subnormal peripheral action of this T3 and T4 is considered as hypothyroidism. Production, secretion, and peripheral tissue action, these three things. Okay, so when there is low thyroid hormones, basically two things will happen. Number one is there is general metabolic deceleration. I said no, you imagine a car in the previous class. So when you accelerate, you are giving more fuel to the car, it will run fast and it will heat up. And when you decelerate, okay, so you are giving less fuel. So you are giving less. When there is less fuel to the body will decelerate. So there is generalized metabolic deceleration now. So what will happen? There will be slowing, okay, across organ systems. So there will be slowing of the brain, there will be slowing of the heart, there will be slowing of the gastrointestinal system, there will be slowing of skeletal muscles, which presents as fatigue and constipation, sluggishness, bradycardia. Okay, that is the first thing which is going to happen. So generalized metabolic deceleration. The second thing which is going to happen is there is interstitial accumulation of hydrophilic glycosaminoglycans. Okay, so there is deposition of these things. What are those glycosaminoglycans? That is nothing but hyaluronic acid and chondroitin sulfate. Where do you find this? You find this actually in joints, no? In joints you find this, and in the treatment of osteoarthritis you use this hyaluronic acid and chondroitin sulfate. So when there is hypothyroidism, there is deposition of these glycosaminoglycans. Okay, so that will lead to something called as some edema. That edema is called as mixed edema, and that is a non-pitting edema actually. So normal edema is pitting edema actually due to any heart failure, liver failure, or renal failure, but in this condition it is non-pitting edema, and typically this edema develops over the shins of the lower limbs. Okay, now, so that's about the definition and core concept. There is subnormal production or secretion or peripheral action of this T3 and T4 that will lead to two basic things: generalized metabolic deceleration, and the second thing, deposition of glycosaminoglycans. Now, depending upon the site, we classify this hypothyroidism into three. Number one is when there is decreased secretion of thyrotropin hormone, TRH, from hypothalamus or pituitary. So that is known as secondary or central hypothyroidism. Example, TSH deficiency from the pituitary. It can be due to any tumor in the pituitary, or it can be due to Sheehan syndrome after postpartum hemorrhage, massive postpartum hemorrhage in pregnant ladies. So that is an example of central hypothyroidism. So this is the first side in the brain. Okay, second side in the thyroid gland itself. So this is the most common form of primary hypothyroidism. 95% of cases are because of this only. So when there is thyroid gland failure, intrinsic gland failure, so the thyroid gland, even though TSH is good, but T3 and T4 will be low. So that is known as primary hypothyroidism. So the rarest one is the third one. So that is peripheral or consumptive hypothyroidism or hormone resistance. Classical example of this is sick euthyroid syndrome, meaning in a patient who is ill either due to some disease, sepsis, or trauma, so TSH will also increase, T3 and T4 will also increase. So the reason for decrease in T3 and T4, one of the reason is uh, deiodinosases, so which are required for the conversion of T4 to T3 are deactivated in your when you're suffering from a disease. So that contributes to peripheral resistance. Okay, that is one mechanism. That's for example one. So this is very rare actually. The most common one is this one. So that's about the types of hypothyroidism: central, okay, depending upon the site, central or secondary, primary, and peripheral resistance. The third one is the clinical classification of, that was anatomical classification, this is clinical classification. So first one is subclinical hypothyroidism. What is that? You will have low T3 and T4 and mildly elevated TSH, but no symptoms in the patient. So that is subclinical hypothyroidism. Second one is overt clinical hypothyroidism. So now the patient will develop symptoms. Okay. The third one is the severe one, mixed edema coma. So severe decrease in the thyroid hormone concentrations, and this occurs because the patient may be having thyroid from many months or days or weeks, and suddenly uh, some disease activity or something happens like pregnancy, something happens to the patient which requires high thyroid hormones, and the patient will end up will developing with this mixed edema coma. So what will happen in that? So there will be multi-organ failure, severe metabolic decompensation, and is a life-threatening condition. So this is the severity of clinical hypothyroidism. First it is subclinical, then it becomes overclinical, then it becomes severe mixed edema coma. So what is the clinical importance and implications? One thing to remember is thyroid hormone receptors are ubiquitous, meaning they are present everywhere. Okay, so that will lead to protean and insidious manifestation. Insidious means gradual, frequently manifesting as normal physiological aging. Number one, very important. Number two, primary psychiatric depression, very important. Number three, intrinsic cardiovascular disease. That means the patient will manifest with these things. So patient will be having less age, but when one looks to the patients, maybe for example, if the patient is 25-year-olds, maybe she or he may look 35 years old. So that at that point we should suspect the patient may be having hypothyroidism. The second thing is the psychiatric one. So there will be a patient who is given antidepressants and still he is having so much resistant to that therapy also, he is not responding to therapy, then one should suspect the patient may be having hypothyroidism. Or it is a good practice that a clinician should exclude in a patient with depression before starting therapy for depression. Okay. Third one is patient will present with features of cardiac disease, like there will be bradycardia. Okay, and there will be increased diastolic pressure leading to diastolic hypertension, muffled heart sounds, and in severe cases one pericardial effusion can happen. Okay, these are the three important things the patient can manifest. So okay, now what is the goal? Timely intervention. What will happen? Prevents profound metabolic decompensation and mitigates long-term cardiovascular and neuropsychiatric sequelae. Okay, so this is one. So these are the two basic things which are going to happen, and this is the anatomical classification, this is the clinical classification, and this is the clinical importance of that. Okay, now let us see the pathophysiology of this hypothyroidism. Okay, classification already we have discussed, and etiology. So pathophysiology, classification, and etiology. Hypothyroidism is classified by its anatomical origin into primary, secondary, and peripheral categories. Over 90% of cases are primary in origin. So secondary or central hypothyroidism. So less than 5% of hypothyroidism cases will be secondary. This results from insufficient TSH from the pituitary or TRH from the hypothalamus. Okay. So what will happen then? There will be dysfunction of HPT axis. Damaged hypothalamus and pituitary will lead to decreased TRH or TSH. That will lead to understimulation of thyroid gland and decreased T4 and T3 levels. So what are the causes for central hypothyroidism? So any pituitary mass, large cellular masses like macroadenoma. Second is autoimmune or immunotherapy associated hypophysitis, meaning inflammation of the pituitary gland. Autoimmune inflammation or immunotherapy mediated inflammation of the pituitary gland. Okay, hypophysitis. Or your patient may be having some brain tumor or something, or some skull cancer, for which he may have received radiation therapy. So that radiation therapy may have led to malfunctioning of this pituitary. Third one is infiltrative diseases, so like sarcoidosis or hemochromatosis, where there is deposition of amyloid proteins in the pituitary, or iron deposition in the pituitary. Okay, and this is more common actually, Sheehan syndrome. So massive postpartum hemorrhage will lead to ischemia of the pituitary, ischemic necrosis of the pituitary. That is nothing but Sheehan syndrome, and this is very important in South Asia region. So five causes we should remember. One thing is any mass. So mass, inflammation. This is inflammation, itis, inflammation. Then irradiation, then infiltration, then Sheehan syndrome. Masses, inflammation, irradiation, infiltration, irradiation, masses, inflammation, irradiation, infiltration, and Sheehan syndrome. So these are the five main causes. Now the clinical logic and paradox, TSH dejection and bioactivity. Damaged pituitary synthesizes, so this is the mechanism actually. Okay, biologically inactive TSH. So TSH will be there, but that is a malformed TSH. This is detected by modern immunometric assays. So now this improperly glycosylated TSH fails to activate the thyroid receptor. Okay, so that will lead to central hypothyroidism. TSH value may be low, normal, or slightly elevated, yet the patient has overt hypothyroidism, low T4. Remember the five important causes of this central hypothyroidism: masses, inflammation, irradiation, infiltration, and Sheehan syndrome. Okay. Now coming this the most common cause of hypothyroidism, that is primary hypothyroidism or intrinsic gland failure. So primary hypothyroidism results from four important causes. So number one is autoimmune thyroiditis or Hashimoto's disease. Number two is iatrogenic hypothyroidism, meaning you are giving some drugs or some surgery that is causing this hypothyroidism due to treatment, meaning treatment induced hypothyroidism, iatrogenic hypothyroidism. Third one is drug induced hypothyroidism, meaning drug which is used for something else is causing hypothyroidism. Fourth one is iodine deficiency. Four causes. And in these four causes, the most common cause again is the autoimmune cause, that is nothing but Hashimoto's thyroiditis. Okay. Now let us discuss one by one. So infographs. I am converting the explanation into infographs now, so we can move fast and our brain retains visual things more than the written things. Okay. So autoimmune thyroiditis or Hashimoto's disease is the most prevalent in iodine sufficient regions, is the most common cause. What will happen there? There is breakdown in immune tolerance. Okay. Why? Because of genetic polymorphisms and environmental triggers. These two things will cause immune tolerance. Polymorphisms like HLA-DR3, DR4, DR5, and these genes. Okay. So patients, most of the patients have family history of thyroid disease in these kind of patients, because they have genetic polymorphisms. Okay, and in these genetically susceptible patients, when some environmental trigger is there, like high iodine intake or low selenium. So selenium is necessary for deiodinases to convert T4 to T3, or some certain viral infections is the most common cause, viral infections. So that will break down the immune tolerance, and thyroid gland will be infiltrated by activated immune cells, T cells and B cells. These T cells and B cells induce death receptors and cause apoptosis and cell death. Okay, so that will lead to the cells will change their shape. So that is known as oxyphil metaplasia. So remember, hyperplasia is increase in the size, metaplasia is change in the form of cell. So oxyphil metaplasia will result and there will be progressive fibrosis. The gland will heal by fibrosis, obliterating the structure of the gland. So this will happen, oxyphil metaplasia and progressive fibrosis. Now what are the diagnostic hallmarks in these patients? There will be presence of thyroid peroxidase antibodies, anti-TPO antibodies, and anti-thyroglobulin antibodies, anti-TPO antibodies, and anti-TG antibodies in more than 90% of patients. So remember, there are two variants in this. One is TSH receptor blocking antibodies and the fibrotic variant. And this is the more common variant, that is TSH receptor blocking antibodies. So what will happen is the antibodies go and they will attach to the TSH receptor. Okay, so that is TSH receptor blocking antibodies. That will lead to atrophic thyroiditis or primary mixed edema. So these antibodies go and block, and normal TSH now cannot attach to the TSH receptor. That will lead to hypothyroidism. Fibrotic variant, so immunoglobulins, IgG antibodies will go and infiltrate and damage the gland. So that is one thing. So either these antibodies go and block the receptor, or they go into the gland and they will damage the gland. So that is about the autoimmune or Hashimoto's disease. Second one is iatrogenic hypothyroidism. So there are three important causes of iatrogenic causes. Number one is surgical, total or subtotal thyroidectomy, meaning you are removing the thyroid gland. So for example, in patient is multinodular goiter. So most commonly this surgery is done for multinodular MNG, toxic multinodular goiter. So when the gland is removed, now there is no gland, so there will be low T3 and T4. Okay, that is one. Second thing is, second kind of treatment which is given in patients with hyperthyroidism is radioactive iodine. Will so through the NIS, meaning sodium iodide symporter, this radioiodine will enter into the thyroid gland, and because it is radioactive, it will have emissions, radioactive emissions in the gland. It will damage the gland permanently. So frequently these two are used for patients with toxic MNG and Graves disease patients. Okay, then the third one is external beam radiation therapy. So this is not used for the treatment of hyperthyroidism actually. Patient may be having some other brain tumor or some head tumors for which he may have received this radiotherapy, and the radiotherapy collaterally damages the thyroid gland. So that will cause your hypothyroidism. For head and neck cancers like laryngeal cancer, Hodgkin's lymphoma. Okay, so that will lead to low T4, T3. Okay, one more important thing is this bexarotene. So it is a RXR agonist. So this will suppress the TSH gene expression and causes central hypothyroidism. Bexarotene. Okay, just remember bexarotene. These four things. Okay. So in hyperthyroidism patients, due to surgery or radioactive iodine, patient will develop hypothyroidism. These are the most common cause. And third is collateral damage by radiotherapy, and fourth one is one drug known as bexarotene. Okay, so which will block the transcription of TSH. The third one is drug induced hypothyroidism. So most common example are three again. Number one is most common is amiodarone. Number two is lithium, very important. Number four is again, number three is bixarotene. Three things: amiodarone, lithium, and bixarotene. So what is amiodarone? Actually, it is a class 3 antiarrhythmic. But the problem is 40% of amiodarone is iodine actually. 40% of iodine, meaning approximately half of the molecule of amiodarone constitutes iodine. That's why it has effects. So remember, in the physiology class we discussed. So whenever there is a iodine overload state, the thyroid gland shuts itself to produce shuts not to produce thyroid hormones. So whenever there is a patient who is taking amiodarone, so it is a kind of iodine overload state. So again here also there is shutting of the thyroid gland by inhibition of thyroid peroxidase enzyme, or blocking peripherally blocking the 5-deiodinase enzyme. So meaning there is both decreased production and increased peripheral resistance. So that is, we have learned, this is known as Wolff-Chaikoff effect. Okay, so this will lead to persistent primary hypothyroidism, especially in subclinical autoimmune cases. Okay, second is lithium. So where this lithium is used, this is used in bipolar disorder. It's psychiatric drug. Okay, bipolar disorder. In patient with bipolar disorder, you should screen first for any thyroid abnormality, and during the treatment therapy you should routinely screen for hypothyroidism. Okay, so lithium will inhibit the secretion of thyroid gland, thyroid hormones. So production is normal, now secretion is blocked due to lithium. So when the secretion is blocked, negative feedback mechanism, TSH secretion is increased, that will act on the normal gland, and in the long run that will increase the size of the gland. So that's why there will be goiter along with hypothyroidism. Goiter along with hypothyroidism in lithium. Okay, so I forgot one more thing, third one, that is tyrosine kinase inhibitors. For example, like sunitinib, and immune checkpoint inhibitors like nivolumab and pembrolizumab. They will cause destructive painless thyroiditis or capillary regression that will lead to rapid permanent hypothyroidism. So these are actually biological drugs which are used in the treatment of many autoimmune conditions like autoimmune disorders and vasculitis conditions. So in those patients there is a risk of permanent hypothyroidism. We should remember that. So bixarotin, again we have discussed, this is a RXR agonist and it will inhibit the transcription of TSH. So TSH is produced less and that will lead to central hypothyroidism. So this will cause central hypothyroidism. This will cause permanent hypothyroidism. This will cause goiter with hypothyroidism, and this causes persistent primary hypothyroidism. So four things. Number one commonest is amiodarone, second is lithium, third is these biological drugs, and fourth is bixarotin. The last one is iodine deficiency. So this is the most common cause globally. More than 2 billion people are affected. So what happens in this is, there is inadequate iodide trapping. Why? Because so in the diet itself the iodine is less. So in the circulation iodine will be less. So when there is less iodine in the circulation, iodine trapping is less. So meaning the raw material for producing the thyroid hormone is less. So that's why there will be less T4 and T3. Negative feedback, there will be increase in TSH and there will be follicular hyplasia and goiter. So this is known as endemic goitrous hypothyroidism. Endemic goitrous hypothyroidism. So that's about the causes. So I've discussed in autoimmune or Hashimoto's thyroiditis. So anti TPO antibodies, anti-thyroglobulin antibodies, and one variant TSH receptor antibodies will be there. And it is the most common cause in iodine sufficient regions. Iatrogenic is because of either surgery or radioactive iodine for hypothyroidism, or it can be due to your external radiation therapy. The third one is drug induced like amiodarone, lithium, biologicals, and bixarotin. Fourth one is iodine deficiency. Okay, that's about the primary hypothyroidism, which is the most common cause of hypothyroidism. In iatrogenic is mainly because of treatment of hyperthyroidism or collateral damage by the radiotherapy, and in drug induced amiodarone, lithium, biologicals, and bixarotin. Now there are some genetic causes, and there is something called as congenital hypothyroidism. Congenital hypothyroidism affects approximately 1 in 2000 to 4000 newborns. If untreated, it results in profound irreversible neurological damage and intellectual disability known as cretinism. The causes are divided into central defects, primary dysgenesis, and primary dyshormonogenesis. So these are the gene defects. Okay, so important to remember is this Pendred syndrome, which we have discussed before. Okay, so where a channel is not there which helps the iodine to pass from the peripheral endothelial cuboidal or endothelial cells into the colloid. So that will lead to goiter, hypothyroidism, and sensory neural hearing loss. And this one also we can remember, when there is this maldevelopment of pituitary. So along with thyroid, other hormones production may also decrease. That is like growth hormone, prolactin, TSH. Okay, so Congenital hypothyroidism is also an important cause of hypothyroidism in South Asian region like India. Very important. So we will see here. See, global and South Asian perspective. South Asian nations, like particularly India, as highlighted by the Research Society for the Study of Diabetes in India and other regional bodies, they have increased risk of this two things: congenital hypothyroidism and Sheehan syndrome. Very much increased. Okay. So congenital hypothyroidism significantly more prevalent in South Asia than in Western countries. And this is often unrecognized due to absence of universal newborn TSH screening programs. This will lead to irreversible mental developmental impairment if untreated. So that is cretinism, no? Already discussed. And Sheehan syndrome, underdiagnosed in low income and remote regions. This is caused by massive postpartum hemorrhage due to inadequate obstetric care. Patients may remain undiagnosed for decades, presenting later with adrenal crisis or osteoporosis. What are the public health implications? So these two are important. Lack of screening and awareness contributes to preventable endocrine morbidity. This emphasizes need for improved maternal health infrastructure and newborn thyroid screening programs. Okay, it is not still introduced in India, but these are important. Okay, screening programs are not there for both mother and child. It should be there. Okay, so now what are the clinical features and red flags of this thyroid hypothyroidism? Okay, let us discuss. The clinical manifestations of hypothyroidism represents a generalized slowing of metabolic and neurological functions. Important. Generalized slowing of metabolic and neurological functions. Because the onset is highly insidious, patients often adapt to their declining function status, attributing symptoms to fatigue, depression, or normal aging. Okay, patient will think I'm having excessive fatigue, or he may be thinking he is depressed, or he is aging. That's why he is having these symptoms. So two things are important to remember. The most common symptoms are these metabolic and general symptoms the patient which the patient presents with. Metabolic in general, and second, psychiatric neuropsychiatric symptoms. These are the most common things and two symptom most common symptom most common presentations. Okay, so patient will feel excessive tiredness. Okay, and patient will have cold intolerance. So maybe they'll be in summer season, he may have feeling of cold, and patient will have weight gain. So what is the reason behind that? So when there is low thyroid hormones, the BMR of the body is reduced. So when there is reduced BMR, heat generation is reduced. That's why patient will have cold intolerance. And the second thing which is going to happen is glycose aminoglycans mixed edematous fluid will be deposited in the patient, and weight gain will be there. Why weight gain will be there? Weight gain will be there because of this deposition of this glycose aminoglycans. Okay. Okay. What are the neuropsychiatric benefits? These are the most important. Remember, tired and cold intolerance and weight gain. Neuropsychiatric, so it affects from brain to the spinal nerves. Remember, so neurological manifestations in brain. Patient may have delirium, may present with delirium. That is a severe thing actually, which is going to happen. And the first thing which is going to happen is the depression. From depression to delirium. So delirium usually you see in mixed edema coma actually, or agitated state also. So depression, and because there is slow conduction via the nerves, there is slow conduction via the nerves. Why there is slow conduction via the nerves? Because this mucopolysaccharide will deposit in the nerves. So because of this slow conduction, there will be delayed reflexes in these patients. So particularly delayed knee jerk you will see. Okay, and again because of deposition of these things, constricted syndromes will develop, like carpal tunnel syndrome in the hand, tarsal tunnel syndrome in the leg. Okay, so these things will happen. Patient will have burning sensation in the palms. Patient will have burning sensation in the soles. Okay, patient may have may have depression, resistant depression. Okay, so that thing we should remember. These are the neurological consequences from brain to spinal nerves. Psychiatric consequences in the amygdala. There is low regional glucose metabolism, which will reverse with treatment actually. So that will lead to three things. One is flat effect. What is flat effect? Patient will lose emotions. Okay, flat effect is nothing but patient will either lose emotion or he will have low emotional drive. So that is flat effect. Second is mixed edema madness. What is mixed edema madness? Patient will be agitated. Okay, or patient may be confused. That is mixed edema madness. So flatness, mixed edema madness. Third one is dementia. So dementia is already forgetfulness. Okay, so these three things due to deposition, due to some changes in amygdala. Okay, flat effect, mixed edema madness, and dementia. So these two are the important presentation of a patient with hypothyroidism. Other things in cardiovascular system, there'll be slow heart rate and muffled heart sound you can hear because of pericardial effusion. Okay, and there'll be diastolic hypertension. Why? Because thyroid hormones are necessary for relaxation of the arterioles. Okay, so when there are no thyroid hormones, there will be constriction of the peripheral resistance vessels. That's why there will be diastolic hypertension in these patients. And in GI, gastrointestinal, so you can have constipation in these patients. Very important. Constipation is, and constipations resistant to treatment. Again, you can say, asides in severe cases you can have. And what are the dermatological manifestations? So there'll be hair loss, brittle nails, periorbital puffiness. Okay. So what are the signs then? There'll be carotenemia due to slowed hepatic conversion of carotene to vitamin A. Remember, so in our body we take carotene, a lot of carotene in diet. So that carotene is converted to vitamin A, which requires the presence of T3, thyroid hormone. So when this is not there, so this is not converted and this will accumulate carotene. So carotene causes a yellowish tinge in the skin, So that is a false jaundice perception which will give to the doctor. Okay, so periorbital puffiness will be there. There'll be hair loss, brittle nails, and yellowish discoloration. What are the reproductive manifestation of this disease? So remember, there is low serum hormone binding globulin and altered estrogen metabolism. So when there is low thyroid hormone binding globulin, so there will be less thyroid hormone which is going to the tissues. So because of that, what will happen? There will be menorrhagia. So MC will be disturbed in female patients. So it is a routine practice whenever there is abnormal bleeding, abnormal MCs in the female patients. It is a routine practice. It is a good practice also to screen for thyroid, hypothyroidism or hyperthyroidism. Patient may have infertility. This is also important. Okay, and patient will have low libido. So MC will be disturbed. Patient will not have any child. Patient will have low sex drive. Okay. Now, in case of what will happen then? So because peripherally T3 and T4 are less, so because of negative feedback, more and more amount of TRH, that is thyrotropin hormone, is released from the hypothalamus. Now instead of, even though this will stimulate the thyroid gland, but collaterally it will stimulate the lactotrophs also, lactotrophs in the pituitary gland. So apart from thyrotroph, it will stimulate lactotrophs in the pituitary gland. So that will cause hyperprolactinemia, and hyperprolactinemia will cause galacturia, nothing but secretion of the milk from the breast. So patient will not be pregnant, but he will have secretion of milk because of hyperprolactinemia, and that hyperprolactinemia is because of stimulation of lactotrophs by the thyrotropin releasing hormone. And if severe, remember this point, and if severe, then again this collaterally it will go and stimulate the breast tissue, and it will cause premature enlargement of the breast. Okay, so this is also an important thing. So these are the reproductive manifestations. So most common are these three. What is that? Disturbed MC, infertility, low sex drive, and this hyperprolactinemia, secretion of milk, and precoccus development of this breast. Okay, these are the manifestations of your hypothyroidism. Okay. So what are the red flags which we should not miss in a patient of hypothyroidism? Very important. So we should not miss mixed edema coma. Number one red flag. true endocrine emergency. Mortality is 20 to 50% despite intensive care. So there will be profound hypothermia less than 30 degrees Celsius. That is the hallmark of myxedema coma, profound hypothermia. Respiratory depression, everything will be depressed. Okay, bradycardia, cardiac depression, and there will be severe hyponatremia. Why? Because kidneys will not be able to excrete excessive amount of fluid from the body, so that will lead to dilutional hyponatremia actually. Okay, and altered sensorium progressing to coma, altered sensorium progressing to coma. All these things are the maybe the presentation of your myxedema coma, and important among this, profound hypothermia, respiratory depression. This one, these three, these two actually, psychiatric and hypothermia. So what's the mechanism in this? This is precipitated typically by infection, trauma, myocardial infarction, GI bleeding, sedatives and narcotics in unrecognizable severe hypothyroidism. Okay, so that you should not miss, myxedema coma. Second thing is, always remember, in a patient with hypothyroidism, he may be having a concomitant adrenal insufficiency. So that is known as Schmidt's syndrome. Schmidt's syndrome. So actually it is a triad of type 1 diabetes mellitus, Addison's disease, and hypothyroidism. Schmidt's disease, concomitant adrenal insufficiency. So a patient who is having type 1 diabetes mellitus, okay, and patient who is having shock because of Addison's disease, okay, shock or chronic adrenal crisis, and now he is developing this hypothyroidism also. If this triad is there, type 1 diabetes mellitus, hypothyroidism, and Addison's disease, then that is a red flag. You should not directly give in these patients. So a patient who is presenting with shock and you are suspecting adrenal insufficiency in these patients, so concomitantly you should also screen for a random blood sugar and also for thyroid hormones also. So patient with shock, you should have TSH done, very important. Why? Because if you give TSH, one thing is he may have hypothyroidism again, but if a patient has hypothyroidism with shock and you are giving thyroid hormones, then that thyroid hormones will deplete the store of cortisol and patient will have severe adrenal crisis in that case. So that's why before giving thyroid hormones, you should replace the cortisol first in these patients. So levothyroxine in undiagnosed Addison's rapidly accelerates hepatic cortisol clearance. So thyroxine will decrease the cortisol and that can precipitate a fatal acute adrenal crisis. So this is not much important. Patient may have pericardial effusion which will lead to tamponade. So already we know Beck's triad in pericardial tamponade. Beck's triad. What is that Beck's triad? So there will be cardiomegaly, there will be muffled heart sounds, and there will be bradycardia, mass effusion, cardiomegaly, and muffled heart sounds. And so these two are actually the most important red flags. One is myxedema coma and concomitant adrenal insufficiency or Schmidt syndrome. These two are very important. Thus first two are very important, and you can remember next are this pericardial tamponade. Fourth one is secondary hypothyroidism manifesting as primary hypothyroidism. Okay, that is very important because the management is different. So when to suspect? If the patient is lacking goiter and the patient is lacking elevation in TSH, that means the patient is having decreased TSH. So patient who is not having goiter and patient who is having decreased TSH and presenting with features of primary hypothyroidism, you should suspect that it is not primary, it is actually secondary, which is manifesting as primary. Because why? Because there is decreased TSH here. So how patient presents? Patient presents amenorrhea, atrophic breast, skin depigmentation, and orthostatic hypotension. Or the patient may have a history of postpartum hemorrhage, Sheehan syndrome. Okay, so the major clue here is there will be decreased TSH. Okay, so that's how you differentiate it from primary and secondary hypothyroidism. Important red flags are the first two, Schmidt syndrome and myxedema coma. Other two are this secondary manifesting as primary and pericardial tamponade. So now the last thing we are going to discuss, that is what should be the differential diagnosis. Meaning, so you have now suspected, you have made a provisional diagnosis of hypothyroidism and you have confirmed it. Now other diagnosis we should before a confirmed diagnosis, what other diagnosis we should think of in a patient who is suspect of having hypothyroidism? Because symptoms such as fatigue, weight gain, and depression are ubiquitous, meaning very normal and present in many diseases, hypothyroidism overlaps with numerous systemic disorders, accurate biochemical differentiation is important. So the first one to differentiate is, so here there are actually 1 2 3 4 5 6 conditions, but important ones I will show. So the important ones are this one. One is sick euthyroid syndrome, depression, chronic fatigue or fibromyalgia, and conditions altering the binding proteins like estrogen, pregnancy, hepatitis, androgens, glucocorticoids. These four are the important differentials to differentiate from hypothyroidism. And these are nothing but in these conditions, like in nephrotic syndrome, protein losing enteropathy, heart failure or CKD, you will have edema. So because of edema, you need to differentiate it from hypothyroidism. Coming to the first important differential, that is sick euthyroid syndrome. So in sick euthyroid syndrome, when the patient is sick, T4 conversion to T3 is decreased because of inhibition of D1 and D2, and there is increased activity of D3. So that will lead to conversion of T4 to reverse T3, inactive. Reverse T3 will be activated. So patient will have TSH either low or normal. Remember, low TSH with low T3. You need to differentiate two important diagnoses. One is central hypothyroidism from sick euthyroid syndrome. And one clue is there is increased reverse T3 in patients with this sick euthyroid syndrome. So other thing is, do not treat with thyroid hormone. It is meaning in patients who are presenting with sick euthyroid syndrome, don't treat with thyroid hormone. It is an adaptive state designed to lower the basal metabolic rate. So this patient will recover with illness resolution. So when this will happen, when the patient experiences sepsis, starvation or trauma. And remember, never ever the TSH will cross more than 20 milli international units in this condition. Okay. So patient will not have more than 20 milli units, international units of TSH in sick euthyroid syndrome. So that is also one feature by which we can differentiate. Other is TSH will be low. Major depression you need to differentiate. Screen all refractory depression or bipolar disorder with TSH. Oh, that's how you should differentiate. What are the shared features? Psychomotor retardation, anhedonia meaning loss of pleasure and loss of interest, that is anhedonia, and profound fatigue. Chronic fatigue syndrome. So patient will have myalgias, arthralgias, extreme lethargy. This is also very common in these patients. Okay. So TSH and FT4 will be normal now, meaning a patient who is having a chronic fatigue syndrome, which will develop after a viral illness or fibromyalgia. So in these patients, TSH FT4 will be normal. Okay. And the fourth important thing is the estrogen, pregnancy, hepatitis. So these will increase the thyroid binding globulin. Androgen and glucocorticoids, these will decrease the thyroid binding globulin. So what happens? The thing which happens here is these affect the total T3 and T4, not the free T4 levels. That's why now it is a rule that you should measure FT4 and FT3 with TSH, not T3 and T4, because overall T3 T4 concentrations will vary depending upon the condition of the patient. That's why it is good that a clinician measures free T3 and free T4 levels, so that gives an accurate diagnosis actually. So as I said, free T4 will be normal. Okay. So rely only on free T4, ignore total T4 values in these contexts: in pregnancy, in patients who are taking oral contraceptives, in patients with hepatitis, in patients who are taking steroids, for example, in asthma patients, okay, or in patients with chronic adrenal insufficiency. So in these patients, always you should measure free T3, free thyroxine levels. Okay. Other things are nephrotic syndrome and protein losing enteropathies. Again, here you will lose the thyroid binding globulins that will falsely lower total T4 again. So that's why always measure free T4 in these conditions. Heart failure and CKD, there will be peripheral edema, dyspnea, pleural effusion, lethargy. So you can distinguish it via the TSH. So in protein losing enteropathies like nephrotic syndrome and protein losing enteropathy, because these thyroid globulins, meaning the thyroid carrying proteins, are lost. So you will have a false perception that the patient may be having hypothyroidism. That's why we should not measure total T3 and T4 in these conditions, also in the conditions where the proteins are lost, like in nephrotic syndrome and in protein losing enteropathies, and where there is up or down regulation of these proteins, like in patients who are taking oral contraceptives, pregnant patients, hepatitis, and patients who are taking steroids. There you should measure FT3 and FT4. So that's about the differential diagnosis of patients having hypothyroidism. Most important differential diagnosis are sick euthyroid syndrome, okay, depression, major depression illness, chronic fatigue and fibromyalgia, and other conditions which alter the thyroid binding globulins. Other things are like nephrotic syndrome and protein losing diseases like nephrotic syndrome and protein losing enteropathy. And the last one is your edema conditions like liver failure or CKD patients. Okay, I think half of this topic we have covered, and next we will see in the next video. Thank you for listening.